pretty much goes without saying, doesn't it, that health is fundamental to a quality of life. And the saying goes, if you haven't got your health, you haven't got anything. Is access to decent healthcare a basic human right, or is it increasingly only for those who can afford it? This is Roundtable with me, David Foster. Britain's National Health Service, the NHS, was introduced in 1948, offering healthcare for all, regardless of wealth. Almost 70 years later, it's overstretched, underfunded, a service in crisis, so say many. In the United States, Donald Trump is repealing Obamacare, leaving tens of millions of people without affordable healthcare. Is that fair? Who should pay when we get sick? Is affordable healthcare becoming unreachable?
This law is helping millions of Americans. It's helping people from coast to coast.
We're going to have a health care plan that's going to be second to none. It's going to be great.
The Affordable Care Act is here to stay.
Repeal and replace that disaster known as Obamacare, which is dying, dying, dying.
I believe that we will win. We will rise. We will rise.
The healthcare debate in the US has been as divisive as it has been long. But beneath the politics are vital, fundamental questions about the nature of our society. If you fall sick, who should take care of you, and who should foot the bill? US President Donald Trump is close to fulfilling one of his campaign promises, scrapping Obamacare. That plan made sure all Americans had access to health insurance and put limits on what insurance companies could charge. But Trump wants to make it easier for people to pick and choose their coverage and reduce the $500 billion the government spends on healthcare each year, money that Republicans say is wasted on an inefficient system. But cuts to government-funded schemes will impact those who can't afford health insurance. By some estimates, it could leave as many as 22 million people without coverage. Private healthcare is about individual freedom and responsibility. It exists in a society in which you choose how you want to be treated and when. You aren't forced to pay taxes into a system that you don't rely on or don't need to use all the time. Public healthcare is based on the idea that health is a universal human right for all, and the responsibility of the state. It takes care of you when you fall ill. You pay taxes to protect not just yourself, but those around you in the community. But which system works best? Britain's National Health Service, like other state-run healthcare, stands in contrast to the US system. It's free at the point of entry for any citizen and promises to look after the poorest. But the NHS is suffering. A lack of funding has put enormous strain on the system, and it's impacting the level of care of patients. Some believe a way forward could be to open it up more to market forces.
Funding doesn't mean necessarily that the provision of the health services also have to be done by the state. And there you have a lot of flexibility. I mean, you can have publicly funded but privately provided health services. And that may be a possibility to consider. But my fear is that once you go into the private provision, you very soon start also financing with private resources, private insurance. And then you have the problem that the poorest people are excluded.
A system that draws on both the public and private sectors is not a new idea. But new, innovative ways of integrating the two could bring about better services for people. Perhaps the biggest challenge will be to make sure everyone, particularly society's most vulnerable, has access to good healthcare.
Well, they have it, two very different healthcare models, one public, overstretched, the other user pays, excluding those without insurance. Is there a better way forward? At today's table. From New York, Dr. John C. Goodman, he's pro-healthcare privatization. Welcome to you. In Washington, former Republican staffer Rodney Whitlock. He says there is no such thing as a free lunch when it comes to health care. To my right, Professor Alison Pollock from the University of Newcastle. She believes the way to a fair health system is through central taxation. And to my left is Dr. Yusuf Elgingihi, an NHS doctor who says illness should not penalise the economically deprived. Thank you all very much indeed for coming in. Dr. Goodman in New York, first of all. Answer as simply as possible, but it's a very complicated question. Which works better, the US or the UK system?
Neither system works very well. In the ideal world, it should be as easy to get health care as it is to get my cell phone repaired in both countries. In fact, what we have are two systems totally dominated by bureaucracies. They're more alike than they are different. In Britain, when you see a doctor, it's free. In the United States, when you see a doctor, every time we spend $1, only 10 cents comes out of our own pocket. 90 cents is paid for by someone else. In both systems, people go outside the system to the private sector to get services they cannot get from the bureaucratic system.
I'll come to you, Mr. Whitlock, in just a moment, but let's bring this into the London studio with the two British doctors I have here. You're looking to get the reinstatement, as you call it, of the National Health Service back to how it used to be. How has it changed?
So in 2012, the Health and Social Care Act 2012 abolishes the NHS, so it removes universality. The NHS is predicated on three principles: that it should be universal, available to all; second, it should be free at the point of delivery and funded from general taxation; and third, it should be comprehensive. You know, people should have the full range of services. So what's happened is that the Health and Social Care Act removes the duty on the Secretary of State to provide universality. So it's no longer universal. And what is now happening is the government is breaking up the National Health Service, denationalising it, privatising it and smashing it into lots of little pieces and cutting and closing services. In the meanwhile, large health service corporations, many American, are actually coming in and tendering for services that were once provided by the public sector. So what this is resulting in is a huge new market bureaucracy, which is very expensive. So we're moving more and more rapidly towards the American type of healthcare system, with the only difference is that it's still funded from central taxation, but increasingly services are being closed and cut and people forced to pay out of pocket or to go without.
I'll come to you in a moment, Dr. Elgingihi, because you've had your life saved by the NHS, so we'll get an interesting perspective on that. But Rodney Whitlock in Washington, D.C., I believe there's been a study by Harvard that shows that most bankruptcies in the United States are because of healthcare finance problems.
Yes, and that was one of the things that the Affordable Care Act, passed in 2010, was supposed to address. It was supposed to try to limit the exposure of individuals for their own finances to health care, because if the exposure to financial loss is limitless, you know, people can go bankrupt from their health care costs.
And have things changed since Obamacare, the Affordable Health Care Act, came in?
Certainly, I think we've seen healthcare bankruptcies go down as people have had more access to coverage. But we're far from settled here in America to getting this right.
And nobody in the UK goes bankrupt because of healthcare bills. Nobody has to make a decision about whether to change their job or the implications for their family because of the cost of healthcare. But that is the daily reality for people in the US. The fear of illness, the fear of catastrophic healthcare costs, and the fear that changing their job means denial, or losing their job means the loss of denial or entitlements to care. And people move in and out of eligibility for healthcare in the US in the way they don't in the UK. So freedom from fear of catastrophic healthcare costs has been a cornerstone of the UK national health system.
Let me talk to you, Dr. Yusuf here. You've said the NHS has been effectively abolished, and yet it saved your life.
Well, abolished in legal terms, really. So just as Professor Pollock has outlined, we're talking about the legislative reforms that have been brought in, but increasingly that is translating into, of course, real changes that are being implemented very gradually due to political expediency and feasibility, because the public, the British public, is overwhelmingly in favour of a public healthcare system. The tragic situation is that it's been converted into a market system en route to a two-tier system that is already in place in many ways.
But let's get this absolutely clear. If the system was broken, you wouldn't be alive.
Well, it's, I was very lucky. I had fantastic treatment at a world-famous centre, but increasingly the NHS is in a crisis that is generated, is manufactured by deliberate policies, because we have a current government that is essentially in favour of privatisation, and sadly there have been successive governments that have been married to an ideology of deregulated free markets and the fact that everything should be run by the private sector. And I mean, comparing us to for example, the US system, there is no comparison. The US system is disastrous for the US population. There are millions of people, if not tens of millions of people, who just don't have decent, affordable healthcare.
Well, let's put this to Dr. Goodman in New York. I think one of the things you've said is that the profit motive, and that's what we're talking about here, companies coming in, marketization, the profit motive is why the market for my phone is so good. So you believe any kind of competition improves the quality of the end service?
Well, let me correct something that was previously said. There are very few bankruptcies in the United States because of medical bills. Sickness causes bankruptcy when people have to leave their jobs and they no longer have an income. But the same thing happens in Canada, the same thing happens in Britain. In fact, there are more personal bankruptcies in Canada than there are in the United States. Now, competition, the profit motive, is the way you get efficiency. It's the way we get efficiency in every other market, and we can get it in healthcare. But right now, the only place where you see a real market in the United States is outside our third-party payer system, and you see that a lot in Britain as well.
Could I
yes, please.
Could I correct you on two fronts? One is, if people lose their jobs in the US, they lose their healthcare coverage. And healthcare, the bankruptcies due to healthcare are loss of healthcare coverage and healthcare bills are still very significant in the US. They do not occur in the UK. The second point is the Institute of Medicine, your august Institute of Medicine, has published a report to show the amount of waste due to the market. Nearly $1 trillion in 2009 were wasted due to the cost of the market. That's billing, invoicing, excess profits, undertreatment and overtreatment, all market transactions. That's your own Institute of Medicine, which showed nearly 6% of your GDP, a total of 18%, is totally wasted. That does not happen in public healthcare systems. So those costs are not experienced in the UK,
and yet,
which is why we're half
if I may say,
of
Professor
GDP.
Pollock, I mean, we spend, the figures I've read, is we spend more on the marketisation of the NHS than we spend on family doctors. So it does happen here too.
And that's
absolutely,
because the NHS has been converted into a market system. So it was originally a publicly provided and owned system, and it's increasingly been converted into a privatised.
So if I give you an example, we used to spend 5% of the budget was spent on administration costs. That's the public bureaucracy. Now, in the States, we know it's rapidly more than 35% of every cent and every dollar that goes on the market bureaucracy. And that is where we're rapidly going to. So money is being diverted. So we're moving from 6% to 30%.
Let's get replies from the United States on this. And we haven't heard from Rodney Whitlock for a little while. Your response to what Alison Pollock has said, if you wish. But I also want to put this point to you. The United States spends the largest proportion of GDP of any developed country on its health system, and yet it seems to be broken.
So we're struggling with some very fundamental questions here in America. First of all, there's no such thing as a free lunch in health care. The care is going to be provided, and somebody's going to pay for it. And so when you start there, you have to figure out, okay, what's the most efficient way of structuring your system? We in the United States are still struggling with that question. What is the right amount for government to pay? What is the right amount for an individual to pay? And so that's one of our struggles. But we also have to deal with the consequence of removing the economic incentive from who provides health care. So if you dangle the carrot of you could make money in front of stakeholders, insurers, device manufacturers, drug companies, the providers writ large, does that drive them towards efficiency? Or is there some government-based magic wand where benevolent bureaucrats say everything is efficient, and it is so? Those are tough questions we're still working through here.
Dr. Youssef, your response to that, but I want to put a couple of points to you. In the UK, it is projected for this coming year that 51% of NHS trusts will be overspending. Last year it was 66%. They cannot control their finances, and yet we are spending more now as a proportion of GDP on health than we were in 1999. Well, what's going on?
So we will have had over this decade something like £40 billion in efficiency savings, or what you and I would call cuts.
Cutbacks.
Yeah, in the NHS. So it's not surprising that the hospital sector and other parts of the NHS are running into deficit. The other problem is privatisation, as we've alluded to, which is that we're now in a situation where if you include private sector outsourcing, tens of billions of pounds of the NHS budget are being spent on running a market and on...
But these people know what they're doing, supposedly, don't they?
But
People
the other...
who run this market are better at
but
running their own business than governments are.
But if you divert the money to big American companies like United or companies like Virgin, then there's less money for the NHS publicly owned sector. So what they do is they go into deficit and they have to close. The government closes them and is diverting the money out. Meanwhile, the private providers like United and Virgin are very carefully cherry picking and selecting the services and the patients they want to treat, which is the American way. And the whole point about a market-based system is it's based on risk selection. The idea that you pick and choose the patients and services you want, not that you have a universal duty to provide.
Okay, well, let's put that to John Goodman.
And we see that in the American healthcare system.
If you're running a business, you want the most profitable customers for you, so you don't pick the sickest people.
Okay, one of the misapprehensions here is that the American system is a market system. It is not a market system. In the United States, we have so completely suppressed the market for health care that no one ever sees a real price for anything. No doctor, no patient, no employer, no employee. So it's totally bureaucratic. The only place really in the world where you see a real market for health care is in the international medical tourism market. So in hospitals in India, hospitals in the Grand Cayman are competing worldwide for patients. You can see the price before you go. You have quality indicators, so they're competing on price, they're competing on quality. And there's nothing in Britain or the United States that compares to the efficiency and the quality that you get when you have true market competition.
Okay, so have you been to India?
Have you seen the people, the 700 million people who have no real proper access to healthcare? It's only a small segment of the rich that can afford Apollo hospitals and the private healthcare system in India.
So how do you improve things? I mean, since we've talked about what's wrong, let's talk about getting things better.
It's not rocket science. The WHO, even the World Bank today, and our Treasury in the UK have all come out to say the best, the fairest, most equitable way of funding healthcare is through progressive income taxation. So in the UK, healthcare costs only £2,000. That's what, $3,000 per head? That's really miraculously small. And that risk is shared across everybody. So we all have that feeling of comfort and freedom from fear.
But
the
should
second
you get
thing
all
is that the WHO
with that, or should you just get basic care?
No, there's no such thing as basic care. You get care according to your need, not according to your ability to pay. And the government's role is to decide on what is actually effective care. Because as you rightly say, the private healthcare industry would sell you snake oil tomorrow at $1 million a head. The government's role, and it's put in structures to do this, but America doesn't have this system. That's why we've got the National Institute of Clinical Excellence, or had it, was to put in a mechanism for deciding what was really effective population-based care that would meet the needs of patients.
Okay, so Rodney Whitlock.
And to make those difficult decisions.
As one of our two US guests, the right to reply on that. The suggestion from Professor Pollack is that we go back to the system we had at the very beginning, which is care at the point of need, paid for centrally in our own taxation.
And publicly owned and publicly
Would that
delivered.
work in any other country?
So in America,
May I say something?
We assume
in a moment, Dr.
that we get the highest quality care at the point of service. That's the presumption that most Americans make, and that they have the right to the care that their doctor thinks is the appropriate care for them. The idea that someone else comes in and determines what that care is that is not their doctor is something Americans are not ready to take on.
Dr. Goodman, you wanted to say something, and then I'll come to you, Dr. Youssef.
Yes, well, however we pay for health insurance, whether it's through taxation for everybody or taxation supplements what individuals can afford, the separate question is, how should health care be delivered? In the United States, our Medicare system for the elderly relies on private insurers. A third of our seniors are in private plans. Those plans are more efficient and they provide higher quality than traditional Medicare. Now, there's no reason why you couldn't do the same thing in Britain. You could have government pay the premium and have the private sector compete. And in the United States, those payments are risk adjusted. So if you have a sicker patient, they pay more than for a healthier patient. So the private sector competes both for the sick and the healthy.
Well, Dr. Youssef, I mean, I know you disagree with that premise, but the point I want to put to you is that the NHS, as Professor Pollack sees it, the NHS of 1948 up to X particular date,
2012,
cannot work financially.
Can. It worked.
Well, look at
it
the
worked
deficits,
for 70
look at the overspends,
no,
look at
because
everything.
actually it's imbalanced.
There are more fat people, there are more ill people, there are more old
Blame the
people.
patient.
Well, it's a fact.
No, but this is not true. Patients are not patients are not the cost pressure. The aging population is not the cost pressure. It's one of the huge myths that's perpetrated. The real cost pressures are technologies and the drug industry, pharmaceutical industry, which is out of control at the moment, and things like our private finance initiative and debt. So we can afford it. It's a political decision. We have afforded it for 70 years. And if we take out the market bureaucracy, we can actually afford it instead of diverting it into the private sector.
That would release tens of billions.
Tens of billions.
We know that the estimates for, so the PFI debt for the NHS, that's private, financing of hospitals and other infrastructure. For the NHS, it's up to £80 billion as a mortgage over the next 20 years or so. For the whole country, the UK's private finance initiative debt for all infrastructures over £300 billion. I mean, that is just astonishing. That is revenue being siphoned off to corporations in the financial sector. It is parasitic rentier behavior that is just wealth extraction. It's unsustainable, and we are now entering...
So the practical advice, rather than returning simply to the way we were, what is the practical
and the NHS
what to do today
NHS
to fix
bill,
tomorrow?
Reinstate it. So it's very simple. You reinstate the NHS. We've drafted over
which is
all
what you're
of
trying
us,
to get through Parliament.
which is what we want to get through Parliament, an NHS reinstatement bill. It fixes a lot of these problems. It takes out the market structures, internal, external, stops the privatisation, and centralises PFI debt and makes it the responsibility of the Treasury.
Okay, to our two American guests, is this cloud cuckoo land that the professor's talking about?
1948 was cloud cuckoo land. 1946.
Sorry, you don't know which one of you should start, so let me go to Dr. Goodman first. Fantasy?
Well, I think Britain needs a lot more privatization. What you need is to allow people to take their NHS payment and buy private health insurance, risk adjusted, so the sick get more to spend than the healthy, and then let the private sector compete to see what it can provide. And I think if you have healthy competition in the marketplace, you're going to find that the quality is better and the cost is lower.
This is purely ideological. There is no, if you look, there's a huge amount of international evidence and data. It's very clear. Publicly provided, owned, funded healthcare systems are more cost efficient and generally, in terms of populations, perform better.
No evidence of that.
And high quality. Yes,
No evidence.
there is a lot of
Rodney
evidence.
Whitlock in Washington,
Do you read
D.C.
my papers on marketisation
You
and
get the
long-term care?
chance to wrap this up.
You guys are ready to go to the United States Senate right now. I'm impressed.
We are. Invite us.
Listen, where I jump in on this conversation is that if someone has the ability to control all inputs, to control the cost, of course you can make a system that's more efficient if you define it that way. But then you have to prove that a more efficient system where you've driven that out, where you control the cost, actually produces a higher quality system that when people have that carrot dangled in front of them, hey, you get to go make money if you do something better. Look at the things that we do here in other sectors in America.
I think you're going to go on with a long list.
They are driven by the profit margin.
Unfortunately, we do not have the time. So thank you very much.
All that makes is important.
Okay, we could go on for a very long time. Unfortunately, it's not a particularly long program, although the discussions will go on long after this. I'm absolutely certain of that. Whether it is taxpayer-funded, user pays, or something in the middle, healthcare is something we all value, whatever the points of view you've heard today. The challenge is to find a way pretty much everybody can access it. Indeed, everybody, not pretty much everybody. Well, thanks for watching. It's been Roundtable with me, David Foster. We'll see you next time. Bye-bye.